Well, thank you very much, and thanks for the opportunity to speak. So I'm going to overlap a little bit, but very briefly. Let's see, how do we go forward?
Continue to send your questions to us. We are recording them all.
So I have no disclosures. So here's my take-home for this. So I'm an American pathologist, so intestinal metaplasia for me defines Barrett's. Now, you've just heard what's happening in Europe, and I'll talk a little bit about that. So intestinal metaplasia defines Barrett, but not all intestinal metaplasia is Barrett, at least in terms of our definition. And you just heard about intestinal metaplasia of the cardia, which as of right now is not Barrett, although we may at some point try to bring it in. And then I'm going to focus on dysplasia and sort of talk a fair amount about sort of our dirty little secret in terms of inter-observer and variability in terms of diagnosis of dysplasia. And then a little bit about what to do with indefinite for dysplasia and sort of numbers of biopsies briefly. Oops, sorry. So here's the initial definition of Barrett, and this is why the British started with this. So when Paul described Barrett initially, he described 3 different types of epithelium, which you can see over here. So a more atrophic gastric fundic type, a cardia type, and then what we've now taken to be as Barrett esophagus, intestinal metaplasia. And then it has to be above the lower esophageal sphincter. Now, so as a pathologist, in terms of getting a diagnosis on a report that says Barrett esophagus, I need to know exactly where that biopsy comes from. You just say lower esophagus, you're probably not going to get a diagnosis of Barrett from me unless I can see where the biopsy is with respect to the LES. So I want to know the length where the LES is and where the biopsy is, or an image that shows me the mucosa going into the esophagus. Oops. And so what I want to see is basically what we see here, which is these goblet cells, so these nice dilated cells that look like small bowel goblet cells. And as was mentioned, these are really sort of a marker, these are a terminally differentiated cell, but these are a marker of an intestinal type of change. And the dysplasias that we see and the cancers that we see within the esophagus are predominantly an intestinal type of cancer. So the assumption is that we go from a metaplastic change to intestinal type mucosa, and then on to dysplasia, and then to an intestinal type cancer, which is why, at least for now, we've defined it using intestinal metaplasia. Now, many studies and centers use an ALCIAN blue stain to try and highlight at a pH of 2.5 to try and highlight these in goblet cells, which you can see here on the right. Many American pathologists have moved away from using ALCIAN blue stains predominantly for this reason we see over here. So this is cardia type epithelium that has a ALCIAN blue positive staining to the surface epithelium, which is abnormal, but it is not Barrett. It is not goblet cells. And so we worry about overdiagnosis of this. Now, whether this represents sort of Barrett 1/2 or the precursor lesion, it may, but my goal is to decrease the amount of Barrett that we have pathologically defined and be fairly strict about it. So, as I said, really the bottom line from a pathologist standpoint is a diagnosis, a bottom line diagnosis of Barrett esophagus should only be made on a pathology report if you know where all the anatomic landmarks are and where that biopsy is with respect to that. So you're pretty safe with long segment Barrett's. When you start getting into short segment Barrett's and ultra short segment Barrett's, a little bit more difficult. At least today, intestinal metaplasia of the cardia is not Barrett, at least definitionally. And as I said, many pathologists are no longer using the ALCIAN blue stain to make a diagnosis of Barrett. Oops. All right, switching focus to dysplasia. So talking a little bit about grading of dysplasia and then some observer variation. So typically we use a 6 grading system. So negative for dysplasia, indefinite for dysplasia, low grade, high grade, intramucosal carcinoma, and then invasive carcinoma. And really our problems end up being this indefinite category, which I'll spend a little bit of time on. And then actually things are changing a little bit as treatment changes. So we used to really worry about going from low grade to high grade dysplasia because that was a huge change in terms of treatment classically. Basically observation, maybe increased biopsy versus esophagectomy. And so it scared the heck out of us as pathologists to make a diagnosis of high grade dysplasia because it was a very severe indication of you were going to do something pretty bad, potentially. That's sort of changed, and now we're sort of moving things down. So, all right, so in terms of, as a pathologist, what I'm looking for on a biopsy is basically looking at the surface of a mucosal biopsy, comparing it to the underlying glands, looking at the architecture of the glands, looking at the cytology, the individual cells, and then inflammation, erosions, and ulcers make my life more difficult. So orientation of the biopsy is important because this surface to underlying glands, whether there's maturation of the epithelium or not, is an important criteria. So a well-oriented biopsy is important. So here's just a picture looking at all these various categories. So we have negative for dysplasia, so we see some goblet cells, indefinite, which I'll get to in more detail, low grade, where we start to see stratification of the nuclei, and that stratification goes all the way to the surface, and it's nicely oriented biopsy. High grade dysplasia, where the nuclei start to get round up, Idaho potato has been described, and also you get necrosis within the glands. Intramucosal carcinoma, where the tumor cells are no longer bound by the basement membrane and are now infiltrating into the lamina propria. And then invasive carcinoma, typically characterized by a desmoplastic reaction. So as I said, pitfalls in the diagnosis and causes for indefinite for dysplasia. Inflammation and ulceration are probably our biggest downside. So you can get prominent nucleoli, enlargement of nuclei, which are things that we think about with high-grade dysplasia. And so as a pathologist, we're very wary about making dysplasia calls in the background of severe inflammation. Additionally, fixatives can change things. Most of us use formalin fixation, but there are other fixatives such as Bouins and Hollands that are used at certain centers that change what we see in the nuclei. And for someone who's not used to it, can change the way you make a diagnosis. Oops. So a couple pictures of indefinite. So here's one that's inflamed. There's lots of lymphocytes, plasma cells, some acute inflammatory cells, and then on higher power, you can see the nuclei are getting a little bit bigger. We got some prominent nucleoli in the nuclei, but they actually all kind of look the same. So if they all kind of look the same and there's inflammation in the background, probably not going to call it high-grade dysplasia. Oops. And then again, this comparison of the surface to the deeper glands. So here the surface glands look okay. The deeper glands start to have some distortion in architecture and rather nasty looking nuclei. And some of these indefinite ones are ones where the potential to call this high-grade dysplasia is possible. Here's another one where the surface epithelium is basically normal, or Barrett, but these glands down deep have features that almost look like high-grade dysplasia. A little bit higher power on those deep glands. Again, these rather abnormal looking glands, and what to do with this could potentially be called high-grade dysplasia or indefinite for dysplasia. The other area where things get a little bit hairy is right at the junction between the squamous epithelium and the columnar epithelium. It's always a little bit more inflamed. There's always more reactive changes, and is a pitfall for pathologists. All right, so reproducibility. So this was a study I was involved with. Liz Montgomery, who's at Hopkins, was our lead author, where 13 gastrointestinal pathologists were looking at about 150 different cases, and we looked at them all twice. So we have intra-observer variability and inter-observer variability, and these are our kappa scores for looking through this. We did a couple reads. So actually for cancer, we were pretty good, invasive carcinoma. For Barrett esophagus without dysplasia, again, reasonably good, and reasonably good for high-grade dysplasia. Where we started to break down is low-grade and indefinite, and especially differentiating low-grade and indefinite. This is a classic original paper from Reed et al., looking at basically the same thing. And so they reported their study initially as basically agreement. We calculated some kappa values to show how that goes with that. And so again, pretty similar in terms of what our study was 10 years or plus later. Again, looking at high grade in cancer versus other, negative versus other, and a few other different groupings through this. This was our study using those same groupings, and again, you can see similar inter-observer variability, still reasonable kappas, especially the one we were most concerned about, high-grade cancer, high-grade and cancer versus other, pretty good agreement. And then this is just a chart basically putting those numbers next to each other. This is the Reed study, this is the Montgomery study, and you can see they're fairly similar in terms of the kappas. So reasonably good intra-observer variability. So now I'm going to show you the bad one. Oops, where did it go? Oh, I lost it. Sorry. So there was a, sorry about that. There is a study out there that was published in 2015 that basically looked at a study with study of treatment of high-grade dysplasia using radiofrequency ablation. And so they had about 200 plus cases that came into a central reading for patients who were being referred for high-grade dysplasia. Of those cases, only half of them were actually confirmed to be high-grade dysplasia by the expert panel, which meant half that were coming in for the community pathologists were either overcalled or undercalled. And the majority of them were overcalled. Something to the order of 40% of them were overcalled in that. So there certainly is, and our study was looking at expert gastrointestinal pathologists versus the community pathologists. So there is definitely an overcall in terms of high-grade dysplasia within the community. So the standard typically for high-grade dysplasia is to get 2 pathologists to look at the specimen and agree that it's high-grade dysplasia. Now, as I mentioned, if we look at the spectrum of histologic progression from these, you know, it's a progression, we think, and what we were really worried about once upon a time was low-grade to high-grade because the intervention there was esophagectomy versus sort of observation. Now that's changed a bit as we've got new ablative techniques, and so really what may actually be more important is this intramucosal to invasive cancer differentiation, because now you're talking about whether you're going to do local therapy versus, again, esophagectomy in here. And so depending on where you're working and what your setting is, the degree or where we really, the sort of pressure point may be different. And with that, I'm going to stop there.
Thank you.
Thank you.